to review the fundamentals of panel identification. Second is to review the tools to assist you with your panel identification. And last but certainly not least, we're excited this afternoon to have ASaP examples from the field. And we'd like to thank Lana DeBoon from the Associate Medical Clinic in Peace River, as well as Christine Osbalduston from the Alberta Heartland PCN for joining us this afternoon. So thank you very much, ladies, for taking the time out of your busy schedule to be with us today. Next slide, please.
Sorry, Lori, technical difficulties.
No worries.
There we go. There it is.
Thank you very much. The College of Family Physicians of Canada reminds us that the definition of panel is the unique number of unduplicated patients that have an established relationship with a primary care provider, underscored by an implicit or explicit agreement with the identified provider who will provide those primary care services. Now, a couple of keywords that come out of this definition are implicit and explicit. So when we think of implicit, an example of that might mean a patient who the same provider has been seeing for the past 20 years, or a patient who lives in a particular rural remote setting where there is only one clinic and perhaps one provider for the entire community. When we think of explicit, what we mean here is that there's a process in place to confirm that the patient and the provider have a care relationship that exists, and this can be either asked of the patient in a face-to-face situation via the phone, or in some cases, a formal signed agreement. Next slide, please. So we've seen this particular slide in our training sessions as improvement facilitators. And with this slide, historically the system is excellent at siloing us or compartmentalizing us into fragmented care. But in order to provide a holistic screening approach using opportunistic or outreach methods, we're actually promoting that holistic approach for screening our clients or our patients. And at the basis or at the foundation of this is the panel. Who are our patients? And the panel is considered fundamental in order for us to achieve excellent population-based screening. Next slide, please. So 3 foundational elements for panel identification. First is continuity. Continuity is the percentage of time that our patients see their own identified primary care provider with whom they have that continuous relationship with, rather than seeking services from other primary care providers. We know that when this happens, we have improved patient satisfaction, we have improved provider satisfaction, we have improvements in clinical care and outcomes, we have a decrease in ER data, ER visits, we have a decrease in hospital admissions, we have a decrease in the length of stay. Last but certainly not least, we also have a decrease in those frequent flyer or follow-up visits. Our second foundational element for panel identification is demographics. Who are our patients? By understanding the particular characteristics of our panel, their ages, sex, etc., this allows for population-based care planning and can serve to provide valuable information to guide our decision-making for clinical processes and priorities, around screening as well as prevention and disease management. So when we think of demographics, it includes obviously the individual's name, their PHN number, date of birth, gender, phone number, and how can we connect with them, especially with those critical results, certainly an address and their patient status. This all will help us with that panel identification list. Next slide is our third and final foundational element for panel identification, and that's standardization, which means that we're doing the same thing the same way every time, no matter who is doing it, no matter what time of day, what week, what month, or what year it is, that we are consistent in doing what it is we're doing. All right, I'm now going to pass the presentation to Lori Choma to lead us through the next few slides before we invite our guest presenters. Lori?
Thank you, Lori. Yes, you're getting the Lori show today. So identifying panel processes. So we have provided you with two key questions to ask your providers when you're going in at the initial stages to look at what processes might be in place in the clinics. And those key questions are, does the patient record indicate the provider responsible for screening, and can the team or provider generate a list of the patients who are attached to the provider? And these two questions can appear quite simple and straightforward, but I think as we're going to hear in our examples, it's not just always a simple yes or no answer, and sometimes teams really aren't aware of what those questions are. And we first have these questions come up for us in ASaP when we're completing the super form. So we have this ASaP tool to assist you, the panel process development checklist, which helps you to determine if there are panel processes in place and just take you a little bit deeper and provide you a little bit of guidance when you're asking clinics those questions. We also have this tool, the panel process assessment tool, which helps you at that next step when you sit down with teams. We'd like to actually thank our friends down in the Chinook region who developed this tool for us, clinics who are using it, those panel admission and discharge processes that they've pre-populated for us to help queue clinics through. It's a pretty thorough tool for those of you who have used it. But we're getting excellent feedback on the tool to really help us to talk to teams about how those specific items are confirmed, how it's being documented, whether it's in a paper chart or electronic medical record, and who's doing that work. Because it's really important that those processes get standardized, as Lori pointed out to us. So if there's more than one person entering that information, we want to make sure that it's being done at the same time, or the same time every time. And it also lets us know when it's being done. So we have this framework here for our panel process development, which you would have seen a few times through your ASaP screening, and that is our trustee model for improvement. So we use this to help guide our team through the improvement process. And it's no different when we're looking at working specifically on improving our processes around panel. So we can set an aim to help us decide what we're trying to accomplish around our panel processes and what our end goal is with our panel. Some measures, and that can be really just counting how many patients are currently on our panel and where are we going to get and figure out what that goal is. And what changes are we going to make? So what is that standardization going to look like? Who's going to be doing what, and when are they going to be doing it? And of course, as always, we use our PDSA cycle, our plan, do, study, act, to help us guide us through that process when we're looking at panel. So without further ado, we would like to pass the floor over to you, our improvement facilitators out in the field. And we had a couple of volunteers to help us out this time to share their panel processes. And so I'd like to pass it over to Lana DeBoon to tell us about their experience at the Associate Medical Clinic in Peace River. Lana.
Thanks, Lori. Can you hear me okay?
Yeah, great.
Okay. So first of all, thanks for inviting us to present our panel work to the group. This is something that's fairly new for us. First, I'll introduce our core team, Angie Weston, who's executive assistant for the PCN and also assistant manager for the Associate Medical Clinic. Janice Tukey is a clinical assistant, so she works in the clinical side of things, and I am the executive director for the Peace River PCN. So in the past, we often talked about how we could make our panel more accurate, but it wasn't until we attended their learning sessions through the ASaP project that we finally felt like we had the skills and the tools to really do something about it. So the first step for us was running a report from our EMR that told us our current panel information. And that report showed we had over 66,000 patients listed as active in our EMR. And when you consider the population of the town of Peace River, which is approximately 7,500 people, we knew that we were way off on our panel. So even with all the surrounding communities that we take care of, we estimated that our panel shouldn't be much higher than 10 to 15,000. I think you can go to the next slide. Right, so our process in the past was that when patients were added to the system, they were always added as active. We never had any process in place to inactivate patients other than if they were deceased or they were a duplicate chart, really. So what do we do with all these patients? The core team decided we would start by using the panel process assessment tool that was provided in our ASaP binders. So we got our team together, and together we filled it out, starting with what we were currently doing, and then adding what we thought should happen in the spaces where there were no processes. And I just have to say Angie was instrumental in this step because she does the majority of training for new staff, and so she knew the current processes really well, and she was also able to offer good suggestions for new processes. We then emailed the document to all staff for their feedback. And I'm not sure if that's on the next slide, the one that we filled out.
Have it there?
Not yet.
Okay, there's a bit of a delay.
Okay, so there's the one that we filled out. So basically just followed the whole template, and it worked quite well for us. So there were a few tweaks of the document. It went back and forth, lots of questions from staff. Well, what about this? What about that? And so we finally got it to the point where we think it's fairly straightforward. And so once it was done, every staff person received a hard copy of this document. So it wasn't really hard to convince staff that this project had merit. I mean, who wants to screen 66,000 patients? The physicians were a little less enthusiastic about it, but as long as they didn't have to do the work, they didn't complain. The processes we had just put in place were great for moving forward, but if we didn't do something about all the people we'd seen in the past, it would take decades to clean up a panel of that size. So we started with patients who didn't have a family physician listed, so we call those unassigned, and who had not been seen in the clinic for over 7 years. And these patients were automatically listed as inactive, and we were able to use our EMR to change the status in batches, so we didn't have to do it patient by patient. And we could only batch 200 at a time, though, so it took a few hours to complete this step. But this first step allowed us to inactivate 34,000 patients in one fell swoop. So if any of those patients end up coming into the clinic in the future, it's very easy to just go in and change their status, back to active or to temporary. Our second step was then to change all patients who had been seen in the clinic in the past 7 years, but who were unassigned to a panel, to temporary status, which we'd never used before. So this resulted in 22,000 patients being labeled as temporary. So just in the first 2 steps, we were able to change the status of about 50, what does that end up to? 56,000 patients. The next step was changing patients who were paneled to a physician, but hadn't been seen in the past 7 years. And we were going to change those to inactive, but after running our reports, there were less than 5 patients per physician who hadn't been seen in the last 7 years. So that was a pleasant surprise for us. So after those 3 steps, our panel came down to numbers that looked much more reasonable. So we have about 8,000 paneled patients and another 2,000 that have been orphaned by 3 physicians who've left over the past year or so. And then we had to figure out what to do with our nurse practitioner. We'd never paneled any patients to the nurse practitioner. So we had to kind of build a process for this. So we ran a few reports, discussed it with the nurse practitioner, and kind of landed on any patient that she had seen 3 or more times in the past 4 years since she started with the PC, who were unattached would be paneled as hers, and that was about 300 patients. And she thought that was reasonable. So that was our panel work. We still have a few challenges. The first is that very few patients contact our office when they move out of town, unless they have significant health problems. Secondly, we're often not notified when a patient passes away. So we were discussing these 2 challenges at one of our meetings, thinking about whether the funeral home would be able to let us know somehow when patients passed away. We just have one funeral home in Peace River. And someone mentioned the wonderful website that the funeral home had, and the light bulb went off for us. Why can't we just access the website and find out who passed away? So again, Angie took on this task. She was able to go back 2 years on the website, and she found approximately 173 patients, I think, that had passed away that we weren't aware of. So now our biggest challenge remains how to find out when people move away. This was confirmed when Janice started to do the chart reviews for ASaP. Out of 20 charts she's reviewing per provider, she's finding that up to 25% of those have moved away. So our numbers aren't looking very good for our chart reviews. We've started a process where when we receive chart transfer requests on patients, we are marking those patients as inactive when we send the records to their new physician. So that works great for patients who actually have their chart requested, but a lot of patients who are healthy never do request their charts. So those ones are, right now are going to remain active until they haven't been seen in our clinic for 7 years. We're thinking we might be able to catch them sooner if we start offering outreach screening, but we would love to hear from anybody on the call if anybody has any suggestions or things that they've tried in regards to this issue. And the final thing we did over the past week or so was to flow map the check-in process at the front desk. As our receptionist stated, she was occasionally forgetting to update the patient's status. We're hopeful that the map we've created will help her and future staff and receptionists to make this part of their routine. So it's great to do all the work, but it has to become part of the routine. One thing that we found that was a kind of a bonus for us is that when we labeled patients as temporary, they turn yellow on our scheduler. So it's really easy to pick them out from paneled patients. And we found a few that were labeled as temporary that really were paneled patients. So you can really see them and say, oh, we've been seeing that patient for years. So that's been a helpful thing for us to catch those. And then the last challenge is within those temporary patients, there are some that should be paneled to us, just they haven't been able to get a physician because there's just no access in Peace River. There are no physicians taking on new patients. And then there are some also in that temporary status who would be just coming here for specialty services such as obstetrical care, surgical consults, anesthesia consults, GI consults, etc. So those patients would never be paneled to us. So it's a little bit difficult to say for certain how many patients in Peace River are we not taking care of that we should be taking care of. So that's been our journey so far. We think we've come a long way, but there's still a ways to go. Does anybody have any questions for us?
thinking everyone might still be gasping from the numbers that they saw. That's pretty astounding. So congratulations on that. But yes, we'll take some questions from the audience.
Or suggestions about the people who move away. That would be really helpful.
Do we have any facilitators on the call whose teams have asked the same question? Perhaps you're wondering the same thing, or perhaps you have a solution strategy that could be tried elsewhere. All right, we've got a quiet, shy bunch, so we'll let you think on that. If there's any questions for Lana and her team in Peace River. And so what I'll do now is pass the floor on to Christine from the Alberta Heartland PCN to share her story. So Christine, the floor is yours.
Thank you. Hi, everybody. Can you hear me okay?
Yeah, great. Thank you.
Okay. So yeah, our case review and a bit of our situation so far are going to be in context within our walk-in medical clinic here in Fort Saskatchewan with Dr. C. So this clinic has been around since 2003 and has been a walk-in medical clinic since 2003. She has a panel of approximately 1845, and she does see a combination of a few walk-in patients, but also has a set panel patient list as well. And they've been using HealthQuest as their EMR since 2003, so that's been a good thing in terms of getting started with the process. And it's also actually a really great opportunity for me too, because this is actually the very first physician that we've been able to sign up and actually start work with within the ASaP program. So it's certainly been a learning experience for me so far and for the clinic as well. Next slide, please.
On the right slide, reviewed questions, Christine?
Yeah, that's right. Yeah, that's right.
Okay, so I think I've just got quite a delay from you, so my apologies.
That's fine. So the process that we started for our chart review once we had all the consent signed and such things was obviously to review the questions as part of the super form with regards to panel management. And it was very interesting because my conversation with the clinic lead, who's also been involved with that clinic with the same physician since 2003, so they've worked together for quite a while, was that they could certainly pull a list of her panel patients, and they were confident that it was patients that were attached to her and on the panel, and that everything in terms of panel management was hunky-dory and going well. So I said to Sandy, yay, like we're good to go. We can go in and start doing our charts. So we booked some time to go to the clinic and do that. And within the first 3 charts that we pulled, we knew there was some sort of disconnect. So the first chart we pulled, the patient hadn't been seen by this particular physician since 2008, although there was a hint of some screening happening as a mammography screening had been completed. The second chart, the patient had documented visits with a number of the other providers within that same clinic, but very few with this particular physician. And then the third chart that we pulled, again, had a number of visits within the clinic, but nothing that specifically tied this patient to Dr. C. So then, just so that Sandy and I felt comfortable with where we thought the results of this chart audit were going, we did pull just a couple more charts at random. And again, with a few more that we looked at, there was just nothing substantial within the documentation that we could tell that indicated some type of attachment. So, like annual physicals or blood pressures, heights, weights, labs, that type of thing. For the most part, we saw lots of examples like a UTI or an upper respiratory infection, things that you would really link to just typical walk-in cases. So then our challenge became the fact that the clinic and the staff that's working with me within the chart auditing process seemed really confident that they could identify that panel and that they were willing to pull all sorts of lists and reports from the EMR to confirm that, but the documentation wasn't necessarily reflected in the EMR. And so how do we address the discrepancy with the clinic? As certainly the discrepancy will impact the screening rates for the chart audit at the time of the post, when we get to the post review. So our next step then to deal with that challenge was to work with the clinic to create and meet with the improvement team to discuss panel management strategies. So actually on Thursday, I sat down with Dr. C, the nurse practitioner that she works with, their clinic lead, as well as their lead MOA and reception staff member. So it was actually a really great meeting. And we talked about this whole idea of panel. And it was interesting because Dr. C did at first, again, within the first couple minutes of us sitting down, did validate the fact that she felt, her panel was well identified and that she was doing a fantastic job of screening, which we know for family physicians does happen. And, like she was a bit unsure about why we were having the issues that we have. And so it was interesting as the conversation continued and that we brought up, some examples of potentially some things that might change. She was enlightened. For one instance was this clinic does offer a monthly pap smear clinic, and so she is involved with that. And those patients, because she sees them, do end up under her name in the EMR. And so just a light bulb went on for her, and it's like, oh, you know what, I guess that is happening, and maybe there's a different way that we can identify those patients within the EMR in order to establish panel and to ensure that there's indications within the EMR to identify patients that are just coming, for those one-off reasons. She also does cover walk-ins on occasion when there's short a physician in the office or they get completely slammed with patients. And so as we talked through that, it was like, oh yeah, actually those patients that I see do then end up with my name attached to them in the EMR. And so is there some other strategies or processes and techniques within the EMR that we can use to identify that? So that the meeting went really, really well, and the team was actually able to establish a number of things within the EMR that they are going to try in order to relabel, I guess, their patients. So there's a status button, because they use HealthQuest, there's a status button in HealthQuest that they can utilize. So one of the ideas was to have a couple of different ways of labeling Dr. Carter's patients. So, for example, Dr. Carter panel and Dr. Carter walk-in. So it still identifies the fact that she saw them, but just within those different categories. So that when we would go to pull a report again, we could truly just pull a report on those patients that she's responsible for screening for. Because one of the concerns that she expressed was like, she doesn't want to be responsible for screening for, every patient that walks in. So our processes and the things that we've done within the program so far have led to a number of questions. And so I'm hoping that these are some of the questions that maybe you guys have run into in your work with ASaP so far. And if not, maybe you can help me answer some of them. And actually, some of them have been addressed since we met with the improvement team yesterday. So is there a benefit to determine offers of screening in a walk-in environment? So this one I'm not sure of. I don't know if there's any of you guys have any clinics in your PCNs that are walk-in that are doing ASaP. But however, because Dr. C does still carry like a true patient panel that she connects with and believes is responsible for screening, in our situation it will work. We just have to figure out a way, or the clinic just has to figure out a way of identifying that. And the other question that I had is, how do we address the potential that patients are using a walk-in clinic setting as a primary provider? Should this clinic be responsible for screening those patients as well? So yeah, the situation that they identified within the clinic is that although patients may not specifically pick a physician or the physician pick the patient within the clinic, they still do use a walk-in clinic as their primary provider. So they don't necessarily really care which provider they see. They just consider that clinic sort of their home-based clinic and go there to seek care. And then probably the biggest question that came out of our work so far is, are there some better questions that could be asked in the initial sort of interview component that would help better determine whether a panel management review needs to be done or completed before we actually go in to do the chart audit? Because, like as I said before, the clinic, when I asked those specific questions from the super farm, they were very confident that panel wasn't going to be an issue and that we could just jump right into the chart review, and we learned very quickly that that wasn't the case. And then my final question is, do patients and their clinic staff truly understand what having an identified panel means to their practice? And actually this got clarified for me through our improvement team meeting that we had yesterday. Originally I thought no, because I was struggling with communicating with the clinic lead about what I was looking for and the type of list I was looking for. But after meeting with Dr. C and the team yesterday, they do understand that. They just had a hard time thinking about the context within what I was looking for. So that's it for me, I guess. So, you know, excited to be getting started and running into these situations and learning, and hopefully some of you can relate to some of those situations, and I hope everything's going well for everyone out there.
Great. Thank you very much, Christine. I'm just going to go back a slide because you asked 4 fantastic questions there, and it sounds like you had your first one and your last one answered when you met with your team yesterday. But I still think your questions, you might have 2 that still remain unanswered. So how do we address the potential that patients are using a walk-in clinic for their primary provider, and should the clinic be responsible for screening these patients? So I'd like to throw that out to our group to see if anybody has a response. And I think I'll preempt it by saying I don't think there's a right or a wrong answer here. So see if anyone wants to take themselves off of mute and throw anything out there. All right, Deborah, I think we have a shy group today.
I agree.
Hi, it's Lana here. Sorry. I was just going to I don't have a right or wrong answer either, but I was just thinking, I mean, it would be wonderful if we could screen all patients, I guess, in my mind, but is there the capacity to do that? I guess would be my first thought. So I think I would like to start with screening the ones who I know are paneled, and then if there's capacity to do more, that would be wonderful. Does that make sense?
Yeah, absolutely. And actually, one of the things that this particular physician mentioned in our conversation too is it's not financially responsible for physicians just within, their payment model right now to screen patients that aren't necessarily attached to them either, right? So yeah, it makes sense. Not to, I guess, but I'm just trying to think of maybe the potential of a bit broader definition, maybe.
Would there be concerns about once somebody's done the screening for the patients that they would continue to be responsible for those patients? So could there be some backlash down the road?
Absolutely, yeah, I agree.
Yes, that's always a concern that physicians have, and something that they need to ask of the CMPA. Yeah, great. Thank you for that response. So, should they be responsible? I really think it just goes back to the individual physician and the clinic and physician philosophy around that. I think we know, for those of us who have done some AIM work or been exposed to AIM, we can't expect one physician to do everything for all patients. So there is definitely a limitation to what one physician can do. You may be one doctor in a town of 1,000, or you may be one doctor in a town of 10,000. And you certainly can't do for 10,000 what you can do for one. So there's a lot of conflicting, not conflicting, but yeah, a little bit of a. They have to be reflective on what it is they can achieve given their circumstances. So there's your second question there, Christine. Are there some better questions that could be asked to determine panel management?
I guess, and I was just reading my question. That's not necessarily better questions. That was poor. That was poor phrasing on my part. But maybe some additional questions, or maybe some more specific questions.
And is that more specific than what's on the panel management tool? Are you thinking?
Or the super form. And Ashley,
okay.
Lana's presentation brought to mind some great things for me, because I haven't pulled out that panel form yet, and so that's one of the things I'm gonna do the next time that we meet with the improvement team for this clinic, is certainly look at that, because those questions will be very helpful. I forgot about it. That's the trouble with doing training. Seems like so long ago already. I completely forgot about that tool.
Okay. Yeah. So there are those two questions on the super form, and I will remind you that we are looking at from the one perspective is the physician's perspective on their panel. And it sounds, Christine, like when you asked those questions, you got a different answer than what you actually found when you went in reverse and actually had the opportunity to look in there. So that's a great question. I can take that back to our team, and we can maybe post that response on Yammer. You'll be at that.
And I guess the other component to that too is there other examples from those of you out there, starting your chart audits and within that same situation? So, there's the clinic or the improvement team or the people that you're working with within the clinic are saying, yes, I think we do have an identified panel, and then when you go to start the chart audit, that's not the case.
I should run all these off. Do we have anyone in the audience who's run into something similar?
Sure, I'll speak to that. This is Sandra from Southside PCN. I haven't done the actual chart audit yet, but I just yesterday actually completed the super form with a physician, and so it's a bit of a different scenario. But he answered the questions really honestly and kind of followed up with, my panel isn't perfectly identified, but I don't really care. So then I'm not really sure how to. Where I go from there to try to motivate him to identify his panel a little bit better. He had identified his panel about 3 years ago, and he just kind of found it sort of useless. He's also a solo practitioner, so anybody who comes through his doors is basically his patient. So I didn't really know how to answer that.
Okay, is there anyone out there who wants to take a stab at that or who's run into the same issue? Okay, so Denver, a couple of things. We do have the panel guide that's in your binder, and they're in draft form. And there's information in there about the importance of panel for looking at population or the health issues of your population and being able to target programs and intervention as well, of course, as for screening. And it may just take you coming in and doing the chart review for this physician and moving to the next step for him to start to see the importance of it. So not every physician will see the importance right off the bat. So sometimes just feeding them with this bit of information can be helpful. And I'll use an example because I ran into this when I worked with a clinic on another initiative where our first step was to look at panel. And so when I went in to do the chart review, the score was pretty poor for this physician. And when I actually ran the report, I couldn't go back and see the patients who'd been reviewed in the chart review and say, well, this happened to this one, this was the case with this one. But I was able to run a report and say 2/3 of your patients haven't even been in the clinic in the past 6 years. So that's why your score wasn't very good. And our next step is to look at the patient panel and try and increase our rates of screening. And so it was at that point where they looked at the panel in a little bit of a different way.
Okay, thanks. Yeah, that's helpful. And I need to read that the panel identification guide. It's on my list of things to do.
So, if you get that kind of pushback, it doesn't matter. We're just trying to whet physicians' appetites. We're just trying to get them thinking about these things.
Yeah, and I don't know that it's pushback because he's totally 100% on board. He just wants to get it started, and he doesn't want to, because he's done panel work before, and I think he just doesn't want to have to deal with it again. He just wants to get to doing the screening more effectively, kind of. And actually, like, his motivation is more trying to figure out how to enter in his data in discrete fields rather than just in the narrative.
Yep. And so, I think that's fine. He's moving toward improvement, and he's going to make improvements. And if he's going to be looking at opportunistic processes, then he'll still make improvements. And that's really what we're looking for, right? We're not looking for perfection in the initiative. We're just looking to say, where are we now, and where can we get to? Where can we accelerate physicians and their teams to? Great. Are there any final questions for either Lana's team or for Christine? Okay, well, thank you to you both for taking the time to put that together, and congratulations on the progress that you have made with your team. And we look forward to hearing more updates from both of you. Of course, we have our Yammer online tool that you can update us on, and then as well as the rest of you out there working in the field with your team. As you have challenges and successes, we do want to hear about them and how you're doing. So just a couple of things in wrap-up. There was definitely a couple of themes that I picked up on, and one of them was around facilitation of the process. And the Peace River team didn't really hit a lot of resistance with what you were doing. You got your team on board and started going forward. So the facilitation part was quite easy for you. And contrast that with Christine's experience, where there was a little bit perhaps of denial from the team in terms of what their panel was like. So it took a little bit more facilitation skills in that case to really draw out of the team and make them see and understand what that current state was. The other piece was around the patient status, and that was key for both of the presenters, was getting that patient status updated, whether it was to moved away or deceased or that the patient just hadn't been seen, and having them archived. So that was a commonality for the two of them. So just a reminder as well that there are some EMR tip sheets that are coming up onto the top website slowly but surely. So right now we've got 4 EMR tip sheets up there that help you with whatever EMR you're working on to get you some information and tips and tricks with that particular EMR in how you would perhaps change a status or update a status and some of the abilities related to panel maintenance. So I believe we currently have 4 of them up on the website right now, and I know there's another 2 that are in development and probably should be up within the next week or 2. So you can find those under chart reviewing or IF resources on our website, and there's an EMR tab in both of those, and it takes you to another page that has those links to those EMR tip sheets. And one of those quote-unquote EMR tip sheets is actually going to be a paper tip sheet. So it'll be for those clinics who may be working with some of those. I think we have about 20% of our primary care physicians across the province still working on paper. So we'll have some direction on that as well. So just a couple of things before we wrap up for today is another panel report that we talked about in our training, and that's the HQCA, or the Health Quality Council of Alberta Physician Panel Report. So this physician panel report is being made available across the province, and we're working with the HQCA in ASaP to help bring this report out to physicians and get the word out on this opportunity. So just to recap on how this is different is that the information that's coming from the HQCA is not the same as the information that's available in the EMR or the paper chart. It really is another perspective on the patient panel. So HQCA has things that doctors and teams can't see from within their EMR, such as continuity, specialist visits, or their trips to the ER. So a physician can't see from within an EMR when their patient may go see another primary care provider. So the HQCA report just gives them another snapshot of what that utilization looks like, and then provides some great comparisons within their PCN as well as within the zone that they're in. And just a reminder, when they're filling out their consent forms, that there can be 2 panels. They can either use a proxy panel where HQCA uses a 6-cut method to determine which patients are attached to that physician, and they run the report based on those physicians. Or there's the opportunity for the physician to submit their patient panel, their validated patient panel. If they agree that it's clean, they can submit that to the HQCA, and that report will be run on that panel. That's just a quick note about the HQCA panel report. And just before we close, I mentioned it once, our panel identification guide that we provided to you in your binder. You'll notice there on the watermark, we still have it in draft form, but the panel guide, just based on the feedback that we've been receiving from the field, from clinics working with it in ASaP, the panel guide is going through a little bit of has gone through a revision, and is actually gone to print today for limited release next week at the Accelerating Primary Care Conference. So that will be passed out for wider feedback. So of course we're working with a couple of partners on this, including the college and Alberta AIM, Health Quality Council of Alberta. So much of our feedback with the panel guide has come from within ASaP. So it's going out for some wider distribution and feedback out there in primary care, so beyond some of those participating in ASaP. So we're hoping to see a finished guide early in the new year. So if there is anyone who is on the call who would like to be a part of this formal review, we are just asking, would we pass it out for your contact information? we would definitely be happy to send out the next draft for your review, or if you know any physicians or teams out there that you're working with who may want to take a look at it for us, we welcome that. So please send an email into ASaP, and we would be happy to share that with you. So lastly, I'm just going to wrap up and give a quick summary that, of course, as Lori showed us, panel is foundational for optimizing screening practices. We want to make sure that we have the patient-provider continuity. That's key. We want to be able to maintain the demographics, and we need to have standardization with what's going in and who's entering. And we have the tools to help you through. We have the panel process checklist, the panel process assessment tool, which Lana's team has started working with, and Christine, I'm sure, will be using with her team soon. And then our Alberta panel guide. So we have just a couple of minutes left. If there's any questions, that ends our formal part of our presentation. I'd like to open the floor back up to our audience for any final questions for Lori or myself, or our panelists, or even for each other. All right, well, hearing none, I'd like to thank our guest presenters, and thank everyone for taking the time out of their Friday afternoon. So we wish you a fantastic weekend, and we will see you again here in December, on December 19th, for our next webinar. So thanks again, everyone, and we'll chat with you in just a few weeks.